Welcome to Beyond Journal Club, a collaboration between CoreAM and NEJM Group.
The goal of Beyond Journal Club is to take landmark clinical trials and put them into context, telling the story of how we got to where we are, what it means for our patients, and how we take care of them.
I'm Dr. Shreya Trivedi, internist at Beth Israel Deaconess Medical Center.
I'm Dr. Greg Katz, cardiologist at NYU.
I'm Dr. Clem Lee at MedPeds Hospice in Boston, and a guest editor at NEJM.
And I'm Dr. Sarah Gorey, a previous editorial fellow at the New England Journal of Medicine and a geriatric medicine fellow at Beth Israel Deaconess Medical Center.
Today, we're diving into the world of bone health, and we're going to be talking about how well do bisphosphonates prevent fractures.
We'll be looking at a recent trial by Boland et al. Of infrequent Zoledronate therapy in patients without osteoporosis to prevent fractures, which was published in the New England Journal of Medicine in January 2025.
And before you all jump on me asking me this question, yes, I am very bummed that there is no cool acronym for this trial.
Too bad, so sad. That's what my 5-year-old would say. Too bad, so sad.
And so moving on, before we get into the study itself, we'll discuss first how to make a diagnosis of osteoporosis and talk about why just making that diagnosis doesn't actually tell us everything we need to know about who should be treated with preventive medicines to reduce fracture risk.
Then we'll go over what drugs we actually have in our toolkit for fracture prevention, and more importantly, what is missing, and why this new bisphosphonate trial was so compelling.
And finally, we'll bring it home to discuss if this changes our practice and how we prevent fractures in our patients.
Whether you're in the thick of residency or just trying to survive a stretch of 12s, you probably don't need one more thing on your plate, and that's where Oakstone CME comes in. They actually get it. Oakstone isn't trying to pile up one more thing on the checkbox. It's supporting you and CME that adapts to you, not the other way around. Whether you're commuting, doing laundry, finally grabbing a moment to yourself, their platform lets you listen or watch wherever you are on your phone, on your laptop, wherever. The ACP Mix App audio companion is one of our go-tos, short, high yield, very manageable, even when I'm running out of fumes. You don't have to carve out a big study block. Just pop in your earbuds, finish a module before your coffee gets cold, and know that you're actually moving forward. Oakstone is CME on your terms because burnout's real and support should be too. Go to Oakstone/Mixapp. That's Oakstone/MKSAP. You can use the code CORE25 for actually 25% off any of their products. It's exclusive to CoreAM listeners. Don't forget to use the code CORE25.
We all know that osteoporosis is characterized by decreased bone mineral density and increased risk of fractures, especially at the hip, the spine, humerus, and wrist. We are talking about mostly postmenopausal women, but another risk factor that we commonly see in osteoporosis is patients with chronic steroid use.
Yeah, and I think we've all heard that scary stat back in med school. After a hip fracture, patients are looking at like a 1-year mortality as high as 28%. And I guess if the main risk factor is osteoporosis, the thought would be that if we can get really good at diagnosing osteoporosis, hopefully we can prevent some of these fractures, right?
You would hope that, Shreya, but I actually have some disappointing news about our diagnostic tools. It turns out that more than half of fragility fractures occur in patients who wouldn't have met diagnostic criteria for osteoporosis before their fracture.
Wait, what?
And that even may be underestimate. I mean, some of the data suggests that 3 out of 4 patients with fragility fractures either had normal bone density or osteopenia at the time of the fracture.
That is wild, Greg.
And because of that, it's likely they wouldn't have really been considered candidates for preventive therapy because they didn't have that diagnosis of osteoporosis prior to having a fracture.
It's such an important truth to get out there. It's really unfortunate fact, but it's so important because this is why the study we will be discussing is so relevant.
Yeah, guys, just so I can sit with this a little better, can you remind me what are the diagnostic tools we do have for osteoporosis?
So radiologically, you look at the DEXA scan. You get that X-ray measurement of the wrist and hip, and we look at the T-score, which is a measure of how dense bone is compared to that of a young, healthy person. Basically, we look at the number of standard deviations from the mean. Osteoporosis is defined as a T-score less than -2.5, and osteopenia is a T-score between -1 and -2.5. Anything higher than -1 is considered normal, healthy bone.
And there is another way of getting the diagnosis of osteoporosis, and that is if you had a fragility fracture.
And a fragility fracture is a fracture due to a minor trauma, such as a fall from a standing height.
Yeah, if you get one of those, then you automatically earn a diagnosis of osteoporosis, regardless of what your bone density T-score measures.
And a third way where you might get treated for osteoporosis is even if you've never had a DEXA scan, people might use the FRAC score, which is a clinical score where you plug in people's risk factors for osteoporosis and it gives you an estimation of their 10-year risk of a fracture. So someone could have a really high 10-year risk for major fractures, even if your T-score on DEXA scan was not in the osteoporotic range.
So we have these various methods. We have a T-score less negative 2.5 on a DEXA scan, or a fragility fracture that can buy you a diagnosis of osteoporosis, or even a high FRAC score could be an indication for treatment.
So to recap, fractures can be absolutely devastating for patients. And while people with osteoporosis are at the highest risk, the unfortunate reality is the majority of fractures occur in patients who don't actually have a diagnosis of osteoporosis. So there's a significant unmet need to figure out who is actually at risk for fractures, and then an unmet therapeutic need to reduce this fracture risk.
That makes me so sad. And I think selfishly, as someone who will probably be at risk in the future for osteoporosis. And I would say, we did talk to a bunch of endocrinologist colleagues in prepping for this episode, and they did point out, yes, we have these validated risk factor prediction tools, and we have come so far in the last few decades in that these prediction tools are helping us pick up those at greatest risk. But it sounds like similar to most things in medicine, right? We still have more to do and really have this unmet diagnostic need.
Wait, Shreya, hold on to that thought. Let's put a pin on that unmet diagnostic need and look through the meds we actually have to prevent fractures. But I promise we're going to circle back if we even need to diagnose osteoporosis in the first place. So the story of treating osteoporosis actually starts in the 1940s when estrogen treatment was shown to improve markers of bone density in postmenopausal women. But then hormone replacement therapy, or HRT, became kind of controversial, so investigators looked for other targets.
And then the bisphosphonate story really starts with the Fracture Intervention Trial, aka FIT. Clem, I think that's a good acronym. Hopefully I approve.
I agree.
Thank you. So the FIT trials were published in JAMA and Lancet in the late 1990s, best decade. But basically the headline here was that there was a significant reduction in fracture with alendronate therapy in one of the studies that looked at women with low bone density and one of the other studies that looked at any history of osteoporotic fractures.
Yeah, but the challenge with alendronate is that it's tough to actually go through the mechanics of taking this drug. You have to take it once a week, which is tough to remember. And then you need to take it on an empty stomach since food reduces its bioavailability. And then you need to take it with a full glass of water and sit up for 30 minutes after taking it to reduce the likelihood of esophagitis.
But there are two additional problems with extrapolating these study results. One is that many of the fractures that were prevented were just incidental fractures seen on imaging. They weren't necessarily symptomatic. And two, there was this concern that arose in the early 2000s about these rare side effects, jaw osteonecrosis, atypical femoral fractures. These are really rare, but if they happen, they're totally devastating. And the press that they got dissuaded a lot of people from taking bisphosphonate therapy.
Yeah, so let's summarize so far. Alendronate reduces fracture risk, at least as measured on x-rays, but it's tough to take and it isn't as effective at reducing clinically symptomatic fractures, which is what most of our patients care about.
Luckily, that wasn't the end of the bisphosphonate story. The FIT trial set the stage for Horizon, which was the first big zoledronic acid study, which showed huge 70% reduction in the risk of vertebral fractures over 3 years in women taking once yearly zoledronic acid. What was really important with this study is that it was IV zoledronic acid and it reduced clinically significant fractures.
So that was the big news. A once-a-year drug that reduces the type of fractures our patients care about.
And some of that benefit persisted for 6 years in the Horizon extension study, even in patients who had stopped getting zoledronic acid after 3 years.
And that long-term benefit is because bisphosphonates have a long half-life, so they have long treatment effects. But this also means you need to surveil them long-term for those really rare side effects.
And the complexity of those risks and those benefits makes the discussion with the individual patient really important. I mean, on one hand, the risk of atypical femoral fracture or jaw osteonecrosis is really low. By most estimates, like 0.1%. But then on the other hand, if you have one of those effects, it's totally devastating.
Yeah, and on top of that, the hard part about atypical fractures is that you have to have a really high index of suspicion for them clinically. They won't always present with trauma, and sometimes patients are just complaining of hip or leg pain.
That's really frustrating, just like some hip or leg pain, and they have an atypical fracture.
Yeah, and the thing with atypical fractures are they're more distal and transverse, so you need a femur x-ray, not just a hip x-ray to make the diagnosis. Also, about a third of these can be bilateral, so you need to image both sides.
Wow, that sucks. And I think the big thing that kept coming up when we talked to endocrinologists was actually how rare these side effects are compared to how much attention it often gets.
Hi, I'm O.P. Hamanvik. I'm an endocrinologist at Brigham and Women's Hospital in Boston, where I'm also an associate professor of medicine at Harvard Medical School, and I am the education editor for NEJM Group. Osteoporosis of the jaw and atypical femur fractures are real side effects. The studies find it fairly consistently, but they're so extremely rare. And that is the take-home to me. And I looked up at some point the likelihood of someone being struck by lightning or the likelihood of someone knowing someone who has been struck by lightning. And it is in the same order of magnitude as your likelihood of having an atypical femur fracture or osteonecrosis of the jaw as a result of treatment with these agents, at least at the doses that we use in osteoporosis treatment. I think the story is different when you start to talk about the higher doses that we use for oncologic indications. So just like any medication has side effects, so do these, but it is so rare that it shouldn't preclude their use to prevent these adverse outcomes.
And one promising thing about these atypical femoral fractures is that the risk is proportional to the duration and also the frequency of treatment, and the risk decreases back to baseline when you stop the drug.
And that risk being proportional to the frequency of treatment will come up really nicely in the study we'll talk about in a second. But say your patient is still concerned about the side effects of bisphosphonates. There are a few other agents you might see your patients on, and we're going to highlight 3 of the major ones.
The first one is denosumab, or as my patients call it, Prolia, which is a rank L inhibitor that decreases bone breakdown. In the Freedom trial, Prolia was really impressive. 40% reduction in hip fractures, 70% reduction in fractures overall when compared to placebo in women with osteoporosis.
Yeah, the advantage of denosumab is that it's subcutaneous and it's only given every 6 months and it doesn't stick around the bone for years.
However, unfortunately, in the follow-up of the Freedom trial, we learned that even though denosumab maintained bone mineral density, at 5 years, investigators had identified 8 cases of osteonecrosis of the jaw and 2 atypical femoral fractures among the 4,550 women that were treated.
All right. So now we know that the rare side effect of, jaw necrosis, atypical femoral fractures aren't just specific to bisphosphonates. And I think my brain just wants to compare the two, right? We said 0.1% for bisphosphonates. It looks like, with the numbers you gave, it's 0.2% with denosumab developing osteonecrosis of the jaw and 0.04% atypical femoral fractures with denosumab.
Exactly. And with longer-term follow-up studies and wider use, another important limitation of denosumab became apparent. That is, once you stop using it, your bone mineral density begins to drop. So if you stop the drug, you have to switch to something else, usually a bisphosphonate.
I think this scenario just reinforces that theme, right? So treatment with osteoporosis, like many things that are chronic diseases, it's a long-run marathon.
And the next osteoporosis treatment option that we have is romosozumab, or as our patients may call it, Evenity. This is a subcutaneous once-a-month drug that works upstream of osteoblasts to increase bone formation and, to a lesser extent, inhibit bone resorption.
In the FRAME trial, romosozumab reduced both vertebral fractures and non-vertebral fractures, and that was included in the secondary endpoint.
Unfortunately, Evenity comes with this black box warning about increased cardiovascular risk because of this signal in the ARCH trial where there was 2-fold increase in major adverse cardiovascular events in postmenopausal women. And so I can't tell you how many patients I've seen asking for cardiac clearance before they start Evenity for their osteoporosis, almost like if they're wishing we had a crystal ball to see who's going to have these cardiovascular events.
Gosh, it's a tough life for those cardiologists.
I think geriatricians have a harder job. And maybe arguably the most important job. I am such a Jerry fan.
Thanks.
Agree.
Okay, let's round out our tour of the non-bisphosphonate treatments that reduce fracture risk in osteoporosis. We have Teriparatide, which is a parathyroid hormone analog that also reduces fracture risk and increases bone mineral density in patients with osteoporosis.
Yeah, the unfortunate thing about teriparatide, it's a daily injection and it's an anabolic hormone, so patients can't take it indefinitely. It's recommended to take only for 2 years, and after that, switch to either denosumab or bisphosphonate.
Okay, so to recap, we have 4 classes of drugs that are used in patients with osteoporosis: bisphosphonates, denosumab, romosozumab, and teriparatide. Each has some clear evidence that they lower fracture risk, but each also have individual risk-benefit trade-offs.
Yeah, so with bisphosphonates and denosumab, we get the worry of the atypical femoral fractures. With Evenity, there's an increased cardiac risk. Both with teriparatide and denosumab, it's a short duration of therapy, and then switching over to another treatment is required.
So we talked about the diagnosis and treatment. And my big concern here is that the metrics we use to decide on treating osteoporosis to prevent fracture aren't all that useful for any given person. They're population-based. And so even though an individual with osteoporosis is at higher individual risk, I'm still struck by the fact that the vast majority of fragility fractures occur in people who don't meet that diagnostic criteria for osteoporosis. And even if you use osteopenia plus a risk calculator, you still miss a fair number of people.
Yeah, it's really unfortunate. Everything we have, which includes T-scores, the FRAC score, and even fancy bone turnover markers for people who are sending those, all of those things are imperfect. And then on top of that, we're not able to predict who is going to have a bad complication once they start treatment.
Yeah, that is the gap. We have these good drugs that reduce fracture risk, but we just are not great at figuring out who should be treated and when. And this brings us to our newest study, which is called Fracture Prevention with Infrequent Zoledronate in Women 50 to 60 years of age by Boland et al., which was published in the New England Journal of Medicine in January 2025.
Oof, that was a marathon. We're definitely going to need an acronym for that. Greg, can I task you as a cardiologist to come up with something?
Clem, I thought you were the acronym connoisseur, but what about if we go with FIZ, Fracture Prevention with Infrequent Zoledronate?
I love it.
From fit to fizz.
So the investigators of this new study asked a pretty simple question. What if we just treat some postmenopausal women with intermittent bisphosphonates instead of waiting until they develop osteoporosis to start treatment?
I think that's a great question, right? If our current predictive models aren't good at figuring out who is actually going to get these fractures, then this is a pretty compelling trial from like a public health perspective, a public health intervention, right? If we could just give this treatment to more people and maybe everyone, will we prevent fractures?
Yeah, so what the researchers did here is that they sent letters to invite 53,000 women aged 50 to 60 who are registered to vote in New Zealand to participate in the trial. They eventually enrolled 1,054 patients and followed them for 10 years.
It's important to say that none of these women had a diagnosis of osteoporosis. Their T-scores were not less than negative 2.5, and they were randomized equally into 3 groups.
And so who were these 3 groups? One group received Zoledronate at the start of the study and then again at 5 years. And just to make it easier, we're going to call this the Zoledronate group. The second group received Zoledronate at the start and then a placebo 5 years later. So we're going to call this the Zoledronate placebo group. And then the third and last group received placebo at both time points. And we'll call that the placebo group.
And overall, this was a pretty healthy group who only had a slightly low bone mineral density. The average age was 56. More than 80% were of European ancestry. The average BMI was 27. The average T-score was negative 0.5. Basically, none of the patients smoked.
Yeah, then they also had a decent amount of physical activity, not a ton of comorbidities. This is exactly the population we want to study. Let's see, can we prevent a lot of fractures?
And to avoid confounders, the participants were excluded on the basis of things that could either substantially raise or lower their fracture risk. For example, they weren't allowed to have taken a bisphosphonate, hormone replacement therapy, or glucocorticoids.
And the primary endpoint was a new vertebral fracture seen on X-ray, but the investigators also looked at all fractures, fragility fractures, and quote-unquote major osteoporotic fractures, which means any fracture at the wrist, the spine, the shoulder, hip, or pelvis.
I thought the tracking for this study was pretty onerous. The study participants had to fill out questionnaires every 6 months on fractures, adverse events, and any changes in their medication. They had formal clinical assessments, and they had X-rays done at time 0, then at 5 years, and then again at 10 years. And 95% of these participants completed the follow-up, so it was a really motivated group who did their homework twice a year for 10 years.
And I also give the radiologist an A+, because the radiologists assessing these fractures on these images use a semi-quantitative scale that actually covers a spectrum of bone issues from deformity and loss of vertebral height to different severity of fractures. So it really wasn't just a binary yes or no. They assessed fractures on a continuum.
It sounds like it's an impressive trial protocol, long-term evaluation, some sophisticated assessments to answer the question at hand. Do bisphosphonates prevent fractures even in people who aren't at elevated fracture risk with their current scores?
So now that we've gone through those methods, Sarah, do you want to do the honor of telling everyone the results?
Sure. I looked at this design trial and I was pretty skeptical, to be honest. I was thinking these results are going to be neutral. It's a low risk, healthy population, and we all know how hard it is to show benefit in a primary prevention trial. But I was pleasantly surprised. Both of the zoledronate and zoledronate placebo groups had a lower risk of vertebral fracture compared to the placebo group.
Yeah, and the absolute risk reduction for vertebral fractures was actually pretty impressive. About 5% absolute reduction in both zoledronate groups compared to placebo. That means we could prevent one vertebral fracture just by treating 20 fairly low-risk women.
And all of those secondary endpoints were positive too. Fewer fragility fractures, major osteoporotic fractures of all kinds. And there was a pretty consistent reduction between 30 and 40% across all of those secondary endpoints.
This all sounds great, but Sarah, you've lived and breathed this research, really brought this to the writer's pitch. I'm curious, anything else that stood out for you?
What really hits me, Shreya, about this is just how many fractures there were. So the investigators predicted that this group of pretty low-risk women without osteoporosis would have, on average, a 9% risk of fracture over the 10 years. But by the end of the trial, a whopping 20% of patients had had a major osteoporotic fracture. So instead of 9 in 100 women having a fracture, it's 20 in 100 women having a fracture. It's a huge increase.
I think that just reinforces the fact that even people who look low risk on paper still have fracture risk. And that's why our predictions are so hard to make.
Right. Another thing that stood out to me, if we just look at the placebo group, 1 out of 3 patients who didn't get any zoledronate at all had at least one fracture by the end of the 10-year study.
What? A third of healthy, middle-aged women who were engaged enough to respond to a letter in the mail were getting fractures? That just seems really unfair.
Yeah, to emphasize that point, people who self-select to join a study may also be the ones who are taking vitamins and exercising and taking good care of themselves. But that's making assumptions because these are people who responded to an invitation in the mail to enroll in a study. But it does speak to a certain level of diligence and engagement and the fact that this is probably not the least healthy living group that you'll see.
I need to switch the conversation now to side effects, right? I feel like once you see an atypical femoral fracture or jaw necrosis, you're so kind of burned by that. And we've talked about it before. So I'm curious, did we see any in this trial?
So I was really relieved when I looked in the supplementary appendix that there actually weren't any of either of those events in either of the zoledronate groups. Yes, I suppose the study only had 1,000 patients, so it's relatively small, but it's still a reassuring piece of information.
You know, something that caught my eye in the supplementary appendix is that I see that there are 6 deaths in the zoledronate group and 3 in the zoledronate placebo group. I don't know. What do you guys make of that?
The confusing thing about that stat to me is, what did these people die from? There may be a small signal with 4 cases of melanoma in the zoledronate group, but not for other cancers. And the theoretical mechanism I would worry about here would be cardiovascular death. But there are no cardiovascular events. And so there's this tiny number of bad events. I think it's really tough to draw any conclusions about that rather than just chalking it up to chance.
So to recap, infrequent zoledronate in this study, either a one-time dose or 2 doses over a 10-year period, reduced vertebral fractures, major osteoporotic fractures, fragility fractures, and actually fractures of all kinds in a fairly healthy group of women in their 50s. So overall, it was a pretty impressive result for the bisphosphonates.
Yeah, and the fact that these people didn't get an atypical femoral fracture or jaw necrosis was also good news. I am so excited to have Echo Core 500 digital stethoscope as a sponsor. I actually learned about them accidentally a year or so ago when I'd forgotten my stethoscope and my resident let me borrow his, and I just was like, wow, I've never heard heart sounds or lung sounds this clearly. You just get this extra level of confidence for those moments where you're asking, was that faint crackles? Was that an S3 gallop? And so that's because Echo's digital stethoscope amplifies sounds 40x. And then on top of that, it has noise cancellation. So you can really hear with precision in a noisy ED or with a really loud roommate or other environments. Echo AI is also built in and helps you detect murmurs and AFib earlier. A cool thing also is that you can record that heart sound that you heard, share it later with your team, or a case presentation. And then you can really trust the diagnostic accuracy. So those who use Echo are twice as likely to catch heart disease. What I think is neat is that Echo 500 isn't just the digital stethoscope. You can actually also get an EKG tracing right on the app when you place an Echo 500 on a patient's chest, so no more waiting around trying to trace down the EKG machine on the floor. I trust Echo so much that I work with a team to create a special offer just for our listeners. Right now, you can get $50 off plus a free customizable chest piece cover at echohealth.com/corium. Your purchase will be HSA and FSA eligible and may also qualify for CME reimbursement. Plus, Echo guarantees you're going to detect heart and lung sounds more confidently, and if you don't, you can return it with a full refund. Go to echohealth.com/corium for $50 off plus a free chest cover. That's ekohealth.com/corium. And with that, let's get back into the episode. It can be tricky to cook meals that are fast, flavorful, and still feel special. I think one of the best shortcuts is frozen Washington red raspberries. These berries are picked at peak ripeness and frozen within hours, so locking in that bright, sweet tart flavor that instantly levels up everything from smoothies to oatmeal, sauces, baked treats. There's no added sugars, no preservatives, just real fruit. And the best part is that they're grown by passionate family farmers in Washington state and harvested with care. They have definitely become a freezer staple in my house. I love being able to throw it in super quick, and it feels like it instantly elevates the recipe with its vibrant color, its flavor. You can find it at Costco, Kroger's, Wineco Foods. You can also find Washington red raspberries in Kirkland's signature 3-berry blend, or Smucker's raspberry jam, or raspberry Uncrustables. Always check the label to see quote-unquote products of the US. And if you're looking for more recipe ideas or cooking tips, you can visit redraz.org. That's redrazz.org. And with that, let's get back in the episode. Now, I think onto the most important part of Beyond Journal Club. What should we take away from this study in terms of how we think about how we take care of patients?
For me, what was really impressive about this trial is that primary prevention is really hard to show a benefit in. And this trial pushes bisphosphonates into the primary prevention space, which is a whole new idea, like the idea of giving the drug before the patient is even diagnosed with osteoporosis.
Yeah, when we were prepping for this podcast, there were a couple of ongoing themes we kept coming back to. And the first was that the bar to treat in primary prevention is different than the bar for secondary prevention treatment. When we're talking about an intervention for an asymptomatic person who is just at risk of a bad outcome, there should be a different threshold before we start to medicalize a person and turn them into a patient.
But didn't we clear that bar? Look at what happened to the placebo group. 1 in 3 women had a fracture over a 10-year period who didn't get any treatment, right?
That fracture incidence is such a good point. If you told a relatively healthy 55-year-old woman, we have to talk about starting medicine to prevent fractures. And by the way, I just checked your T-score. It's normal. I think that patient would look at me like I'm crazy. But lo and behold, look at what happened in the placebo arm of this trial. 1 out of 3 women had a fracture over 10 years.
Yeah, so the most optimistic read of this evidence is that you should just treat every postmenopausal woman with at least 1 dose of Zoledronate. That's kind of what the editorial accompanying this trial said. It would be a small individual benefit, but a huge population benefit.
And that comes to the second idea we kept coming back to, which is that public health officials are going to look at a question like primary prevention of fractures very differently than a doctor who takes care of individual patients.
Yeah, public health officials might see a huge public health impact with this, because hip fractures cost about $30 billion every year in the US, whereas 1 dose of zoledronic acid is less than $100. So I kind of wonder if it's going to make it into like the USPSTF or the Endocrine Society guidelines.
And so you can see that signal for low numbers of those alarming side effects, and it's really great news. But how confident are we that that signal is going to remain the same if this type of study makes its way into the USPSTF guidelines and we really expand the use of bisphosphonate therapy for primary prevention? Do we really know what will happen with a high degree of certainty if we start giving bisphosphonates to millions of women across the United States?
I do want to point out that the jaw osteonecrosis and the atypical femoral fractures are dose and duration dependent risks. So I wonder whether giving this Q5-year infrequent dosing schedule that we saw in this trial would reduce that risk, since the frequency is not the same as would normally be in other trials.
Yeah, that's a good point. I mean, I think if the risk of the side effects is proportional to how often you're getting a drug, then I say let's just offer a one-time shot, because then the chance of having a bad event with 1 single dose is probably very low.
So to me, this is such an attractive strategy. We can give you a shot at 50 and your fracture risk reduces by 30% over the next 10 years. And so you're telling me my mom can go for her flu shot, be hooked up to IV Zoledronate for 30 minutes, and then her fracture risk is lower even though she doesn't do anything else to prevent fractures?
So let's see what some of our other experts and people who live and breathe osteoporosis would do and whether they would give this drug to their mom.
Hi, my name's Dr. Ann Garment. I am the Chief of General Internal and Hospital Medicine at Bellevue Hospital here in New York City. So I'm on team yes, we should do this in an ideal world. I think for me, the kicker is not my concern about the medication in and of itself. I actually have great confidence in bisphosphonates and very little fear. For me, it's just the fact that it's an infusion. I think that's going to be what, is going to make it logistically really challenging to roll this out on any sort of population-wide level. But if you said to me that there was this same trial with a pill, I would say with the same side effect profile and outcomes and whatnot, I would say, no concerns for me. I would absolutely encourage my mom to do this.
Okay. It sounds like we have a strong 2 thumbs up from Dr. Annie Garment.
For my patients, now I am not quite ready to say that a patient with a normal bone density who is in this age group, who's postmenopausal, should receive 1 or several doses of zoledronic acid. I like to see the data out there for a little bit longer, see the reactions of the community, see guidelines get updated potentially. And I think it probably will in the next several years as the results have a chance to seep into our consciousness and, experts discuss and present their take on it. So I think I probably will be considering these results. I think it's always difficult to tell a patient who feels well, who has normal numbers on the measurement that you need to take a medication. It's the same for my patients with diabetes who have, quote, normal cholesterol or LDL numbers, but we don't want it to be just normal. We want it to be extra normal, so they should take a statin. It's a little bit that same thinking of you have a totally normal bone density, but we know that you're at risk of fracturing and therefore we're still going to recommend a treatment. While that is true, I think it's going to be a challenge to have those conversations with patients, especially due to some of the concerns that patients may have read about when it comes to the bisphosphonates.
And this is one of them where the potential benefits are so huge. The prevalence of falls as we get older and osteoporotic fractures is so high. And the risk of these ages is incredibly low. And I think that with all medicines, most people are more afraid of the side effects than they are afraid of what's going to happen if I don't take the medicine. And that's not specific to primary prevention, right? But you think of all the conversations you have in your clinic exam room where patients say, I'm worried about XYZ side effects, even though those are so much less likely to happen than the bad things that could happen if you don't take the medicine. But that's just human nature, right? You have confidence in the future until you don't. And so I think that I can understand why the instinct is quite literally, if it ain't broke, don't fix it.
Man, if it ain't broke, don't fix it. It's so humbling just to think about this topic as a whole, let alone the meds. I think there's just so many parts of it that are underappreciated, misunderstood, not just by patients, but also clinicians.
Going into the pre-work for this episode, I'm not sure that we were all thinking about it correctly. And I've come around to the idea that it's probably not the right way to think about this to ask, does this person have osteoporosis? But instead, I think it makes sense to ask, is this person at risk for a fragility fracture? Because the fragility fracture is the outcome that people care about. They don't really care about what their T-score is. They care if they have a broken bone or not.
That actually reminds me of a conversation I had with one of our endocrinologist colleagues. Maybe we just need to reframe all of this. And maybe instead of calling it a fragility fracture, we make it more of a layman's term. We just call it a bone attack, right? Similar to a heart attack.
Oh, I love that. That's a brilliant analogy. And calling a fragility fracture a bone attack is going to introduce an urgency to the issue and really make us step up our prevention game. And, there's some similarities between a bone attack and a heart attack, like this underlying disease, just like atherosclerosis. Osteoporosis is a slowly progressive chronic disease that shows signs on imaging long before it causes a problem. And then all of a sudden, boom, you have this urgent, almost catastrophic event in people's lives that totally can change their course. And just like with atherosclerosis, just like with heart attacks, we have treatments to prevent fragility fractures, to prevent bone attacks. And I'm excited to teach more people about the opportunities to use them.
Yeah, I'm excited to also see what our listeners think, right? How can we move the needle on the multiple areas we need to make headway on? Is reframing it like a bone attack, kind of taking notes from the cardiology world? Is that going to help? Maybe there's some other good ideas out there, and welcome any thoughts, and please write in.
And with that, it's a wrap for today.
If you found this episode helpful, please share with your team and colleagues and give us a rating on Apple Podcasts or whatever podcast app you use. It really does help people find us.
And thank you to Dr. Jimin Wong for the accompanying graphic, and also to nurse Catherine Gala for the audio editing.
If you have any feedback, please email us at hello@coreimpodcast.com.
Opinions expressed are our own and do not represent the opinions of any affiliated institutions.